Welcome to my Synthesis Leadership Project. I'm Crystal Rivera, and this is being recorded for the University at Buffalo School of Nursing. I do want to point out that the work contained in this assignment has not been previously submitted without prior permission, and to the best of my knowledge and belief, the assignment is my original work and contains no material previously published or written by another person except where due references are made. Introduction. The Synthesis project was developed in conjunction with my supervisors and aimed at improving the quality of care and safety initiatives of the developmentally disabled individuals in their home setting, which are the state group homes. The specific aim for my project was to increase from 50% to 100% the number of calls that house staff make to the RN staff, including nursing grounds, regarding the reporting of individuals who are ill or staying home from day habilitation program through provided training, direct support, and feedback from supervisory staff by May 7, 2019. The importance of this project. Health and safety outcomes of the individuals have been a concern in the group homes. The best interests of individuals have been compromised due to the lack of compliance from staff as a result of the policy and procedures that were in place. So staff were not calling and letting me know when an individual was staying home from their work program or their day habilitation or summer camp, whatever program they attend during the week, or when somebody was showing signs and symptoms of illness. So, as a requirement, they are supposed to call so that the RN has the ability to or the opportunity to head over to the home and provide a complete assessment and then take the next plan of action for their care, whether it may be sending them to the ER or calling their doctor or getting them to an urgent care. The change was a necessity to improve quality outcomes for the individuals. This requirement for patient assessment was a priority. The majority of responsibility is to be placed on licensed nursing staff who possess the capability of assessments and triage. This project promotes nursing leadership at the bedside through the direct leadership of staff within the homes and the patient setting. Forming a team. So we had to get a team together to help me with this project. So I needed some backing sources that actually could help me do this change. So collaborators were needed to gain support and resources needed to implement the changes. The team members included the TTL, which is the overall supervisor. She is the boss of the entire team. So I was on the Perrysburg team. She's the treatment team leader over the Perrysburg team. The NA1, there's 2 nurse administrators, and they are the nursing oversight for the RNs that go and actually provide medical-based care to the homes. The RN2, which was me, and I am the supervisor overseeing the medical aspect of all the homes and any healthcare needs over the group home for every individual within that home, and I currently have two homes. So that's about 18, 19 individuals that I'm responsible for, and we monitor their appointments, making sure staff are taking them to the doctors when they need to, that they are being seen at all the specialists, and any medical concerns that they have, they could call and run that by me, and we'll figure out the next plan of care for them. There is a DA3 and a DA2. They are both house supervisors and they work in conjunction with the direct support aides. They provide direct care to the individuals in the homes, but they also oversee the mechanics and functioning of the house and make sure that the direct support staff are doing what they need to do. The DA3 is actually the supervisor over the entire team of houses, and then the 2 and the 1 oversee the specific home that they work in. So, for example, the one house that I oversee is West Main Street in Perrysburg. The DA1 and 2 are the house supervisors. They provide the direct staff in that home. The 3 is the actual supervisor that oversees every home on that team. And the direct support aides, which provide the direct care to the individuals and get them do feedings, clean, provide pericare, bathrooms, outings, everything that has hands-on with the individuals, you name it, they do it. Team members collaboration. So each collaborator listed as the team contributed to the implementation of the project in their own way. So like I mentioned before, the DA 1, 2, and 3s, They're all mostly supervisors, so they actually assisted me and gave me insight as to what they thought should be included when coming up with the proposal for mandating the house staff to call me within a certain time frame. So this is how we actually got compliance and staff to participate. Uh, Most of the time, they're the ones making the calls to the RNs, so they would call me and report any issues, signs and symptoms of illness, or concerns regarding the individuals. All supervisors assisted in enforcing the new policy and carrying out steps to ensure the policy was being followed. Each team member provided feedback and gave insight into improvements and reported concerns. The treatment team leader gave me the support in carrying out the project, and then we also referred to the nursing administrators because they're the ones that actually have the medical knowledge and background for the homes. As my direct supervisor, the TTL gave me directives to the home and they backed my policy and the staffs need to comply. Change concept. Calls to the house RN from house staff regarding individuals who are ill or staying home from rehabilitation, which is their work program, need to be made in order to assure licensed RNs are given the opportunity to physically head to the home and assess the ill individuals and make informed decisions regarding their next health plan of care. This calls for a safety measure for the staff providing care as well as individuals' healthcare outcomes. Communication between the staff and RN is essential to ensure best practice and increase positive outcome measures. A study performed states that the link between miscommunication and poor patient outcomes has been well documented. To understand the current state of knowledge regarding interprofessional communication, an integrated review was performed. They found that egos, lack of confidence, lack of organization, and structural hierarchies hindered relationships and communications. So with that research that I found, I kept that into consideration and I wanted to ensure the house staff that I wanted to break that barrier of hierarchy. So because many of these house staff have no education, many of them don't even have a high school diploma, and they also feel that anyone who has a degree or is above them look down on them, and I didn't want them to feel like that. I wanted them to know that they can come to me with any concern. And we kind of implement the motto that when in doubt, you ship them out. So if for any reason they think that an individual might be sick, call 911. And that is always our first go-to when we think that there's an issue in the home medical-wise. We have to keep in mind that the individuals that live in these group homes are developmentally disabled. Many of them have multiple comorbidities, and their health status is actually more sensitive than, say, you or I, which are in complete health. In an effort to promote the positive relationships and contribute to increased patient outcomes, change to the communication policy needed to take place. And so I took all this background knowledge and used that as a tool to come up with a new process to change the calling and the participation of staff in the homes. Steps of the PDSA. So the PDSA cycle is used to get changes going, and I use the PDSA to implement my change. And the P stands for plan. So the first step was to brainstorm, come up with a valid change for the particular setting that would meet the objectives and requirements for both the workplace and the course objectives. So when I had to keep in mind that this was being done in state regulated homes, so we had specific requirements that had to be met as well and objectives for the course. We found that the most discrepancies with communication and reporting were that of ill individuals. And a specific example would be one of my homes. We had one individual who's very susceptible to UTIs, gets chronic UTIs, is seen at urology, is on prophylactic antibiotics to prevent her from getting these recurring UTIs. It was to prevent her to get their recurring UTIs, and the staff failed to call me to let me know that the individual was ill She was kept home from day program, was in bed. When I found out that the individual was home, the response from the staff was, quote unquote, she is 3 times worse than yesterday. This is an issue with patient safety. The staff kept an individual home, did not report that she was ill. She was actually in bed. It now was 2 o'clock in the afternoon. She had not had any fluids. This recorded and resulted in an ER visit. I had to have the house staff take her to the ER immediately. So this is why this project had to be implemented, to require staff to report when individuals are ill, because Mary, which is not her real name, is susceptible to having seizures and multiple other issues when she is sick. So then we had to actually do the work and teach the staff the proper communication. I studied any incoming and outgoing calls, who was complying with it, who wasn't, and then in the end we acted and changed the policy. The impact on the practice would be to increase patient outcomes. This would lead to less severe outcomes, put patients less at risk for traumatic injury or negative events, I should say. And so, implementing the spreading of change, we had to take specific steps. We came up with a plan, we followed it. I met with the team. We did a read and sign, which was then sent to West Seneca Training Development. All staff were required to sign and acknowledge that they were required to follow with this policy. And in the event that they do not perform the calls or report any of the health updates to the RN, they would then be uh, get then other actions and measures would be taken by the house supervisors.